Hey guys, so in this quick conditions presentation we're going to talk about the anterior cruciate ligament injury. So etiology and pathophysiology of the condition is essentially a partial to complete disruption of the anterior cruciate ligament. The ACL attaches inferiorly to anterior aspect of the tibial plateau between the anterior spine and the anterior horn of the lateral meniscus, to superiorly to the inner surface of the lateral femoral condyle within the intercondylar fossa. It's more prevalent in females, about 2 to 8 times greater risk, and this is potentially to do with hormonal factors, but again the complete facts on that are unsure or unclear at the moment. It's often caused by weakness in the posterior chain, or there's some reason to suggest that posterior chain weakness could be a contributing factor to this condition. Also can be to do with poor conditioning. A lot of the time these sorts of conditions are more prevalent at the end of games, so when players are fatigued, and therefore the better conditioned a player is, often that this has an impact on these type of traumatic knee injuries. Happens in falls and in contact sports mainly, and again we'll go through the mechanism of injury in a sec. So during your subjective exam, what are you looking for to indicate there may be an ACL tear? Well, you've basically got a landing mechanism of injury on a flexed knee with some tibial rotation and a fixed foot position, often with a change in direction. So when you get that sort of a presentation or report from the patient in terms of what has happened to them, then you should be thinking about an ACL potentially. Often associated with a pop and also giving way, so asking about those things in your subjective is important. Can have pain, can have little pain at first and feel more of a feeling of instability in the knee. And often ACLs are associated with a swelling within the first few hours, or a hemarthrosis of the joint, and this is because of the blood supply in and around the ACL gets just disrupted and then causes blood within the joint itself. Most people are not able to continue sport after having these sorts of injuries, as the giving way feels unstable, and often there's a lot of swelling and a lot of pain with the injury. So after asking them about this is important. Swelling often increases over the next sort of 24 to 48 hours, and often people feel a lot of pain posteriorly in the knee with this condition. Potentially there could be issues if someone's had previous ACLs, then you might be suspecting more likely of another ACL injury as well, especially if they've come back to sport and they haven't had a lot of confidence coming back to the sport. So objectively, what we're looking for, well, first few days we're looking for swelling, we're looking for limp and apprehension when people are walking, we're looking for a reduced range of motion generally with these conditions, especially if there's been some swelling of the joint or a lot of swelling of the joint. Often there's muscle spasms in the hamstring which can occur. This can cause, in often cases, in fact I had my ACL operated and reconstructed, and actually my hamstring was in spasm when I first did the injury, which meant that the draw tests were, I gave a false negative, but actually on MRI the ACL was completely torn. So do have to be a bit careful about muscle spasm in the hamstring, and it can be a prevalent thing with these sorts of injuries. You've got a positive Lachman's and a positive pivot shift test objectively with an ACL tear. And other special tests may be positive if other lesions are present. So you obviously with the ACL you can get a meniscal tear as well as a collateral ligament tear. So medial collateral ligament, medial meniscus, and your ACL is your terrible triad. So you can get those sorts of things being present in terms of special tests for McMurray's or meniscal testing, and also MCL testing as well. Can be difficult to differentiate sometimes when it's acute, and lots of movements can also be sore due to bone bruising that's often prevalent in the lateral condyle in the ACL injury. And this is why it's so important to really get a thorough subjective history, because that's where you glean a lot of your information about what condition the patient may well have. So differentially, you could see a fracture with these sorts of things. So again, you could get tibial plateau fractures with acute in knee injuries. You're obviously thinking about your MCL, your LCL or meniscal tears. You could get patellar dislocations or subluxations with these sort of things. And as I've said before, the ACL can well be combined with other lesions of the meniscus, MCL, etc. Also can have things like quadriceps tendon ruptures, which could have a similar mechanism of injury, but are more rare, these sorts of things, and will have other things that you would expect to find with those sorts of conditions. So in terms of management, essentially, we have copers and we have non-copers with an ACL. You can rehab and see if the individual can cope, and by cope you mean can perform the demands of his sport with no instability, giving way, or issues, so they can perform the sport fine with no problems. If you're finding that the person can't do that because they can't cut, the knee gives way, there's pain in the knee, or any of the above really, then you might want to think about a reconstruction, and obviously surgery to repair the ligament, and this is followed by extensive rehab afterwards. I think it's really important to stress to patients that it's not an easy rehab, and I think that it's important also with certain populations that you really go through what's involved in an ACL repair. I think if someone's a young sportsman, or not even just young, but if they're into their sport and they can't perform their sport because the knee's unstable, then I think surgery obviously is a good way to go, because you're probably not going to get back to the sport without doing that. However, if you've got someone who maybe is more sedentary, and they're not really looking to get back to sport, then you may well find that conservative management would be a much better option for that individual. So I think it is case by case. Obviously, the different surgeries you can have in terms of being a patella tendon graft or a hamstring graft, and this is often based on the preference of the surgeon. Realistically, there's a few pros and cons to each of those things, but essentially, if you're getting that instability as we talked about, then realistically you're going to need to have the surgery. So that's just a quick conditions of the ACL rehab. Give you a few little pointers, hopefully, that you can spot these sorts of conditions. Really common one that you'll see, in particularly with knee traumatic injuries. Hope you liked the video, guys. Please like and subscribe if you did, and share the video with others, and look forward to seeing you on the next quick conditions.